Namaskar, dosto. Good evening. Once again, welcome to Fertility Dost. Let's talk about endometriosis, adenomyosis. Yes, usually when we discuss these two words, we think that are they sisters? Are they associated? Because whenever we talk about endometriosis, adenomyosis just you can say that pitch in, and when we are talking about adenomyosis, then we often get to have some talk related to endometriosis. So today we decided to discuss both of these, and the part of the discussion will be related to this, that whether they are same, they are associated, or they are different, and obviously their impact on our fertility concerns. So viewers, please start pouring your suggestions, your questions, your queries, your doubts related to these two things: adenomyosis, endometriosis, and the most important factor which we will be discussing is difference between both. So we really want you not to confuse with these two. These two are really different. The impact on your fertility is also different. And to discuss this, we have very senior doctor with us from Hyderabad. And for this session, ART Fertility Clinic is our knowledge partner. So let's call the guest doctor on the main screen and just start the session. Namaskar, doctor. Welcome to Fertility Dose.
Namaskar. Uh,
Viewers, we have very senior doctor with us, Dr. Alia Reddy. She is a senior consultant, ART Fertility Clinics, Hyderabad. So, Hyderabad people, just get going the session. I hope that one or the other point of your in your fertility journey, you must seek the knowledge or advice from Dr. Alia. So, in case you have any doubt, please pour your doubts in the comment section and don't hesitate to ask anything. And if you think that you are not like you don't want to ask in the public, then please do message us on our official number and we'll take up your query over here. Dr. Reddy is a very senior fertility specialist and she has treated many cases, whether it's related to female infertility or male infertility. She is an excellent surgeon with doing n number of cases related to hysteroscopy, laparoscopy, and even male infertility cases also. So, Dr. Reddy, let's start with the session and with main topic, the difference between adenomyosis and endometriosis. And usually people says that they are sisters. Is it really so?
Thank you so much for the introduction. Yeah, they are two different entities together, but they are mainly because of the disorder of the endometrium. Disorder of the endometrial lining, which usually lines the uterus. It The impact is different, the growth is different. Both have different complaints, and both have different risk factors. Both have different differences in their how they present themselves. So, one, if you take endometriosis, it usually you see in the younger group where they are in the reproductive group or in the younger group. The other one, the adenomyosis, usually you see in the older group or Paris ladies sometimes, because endometriosis, many people know about it, but adenomyosis, it's just recently getting highlighted. Like recently, people are coming to know about this. So there are still some research going on regarding the adenomyosis. Previously, it was only seen taken out from the hysterectomy. After hysterectomy, when they have sent this for HP, like histopathological examination only, we were able to see the adenomyosis. But with recent advances and all that, we are able to pinpoint the adenomyosis also. And there are some cases where you have both. Certain few patients where you can see both the factors, like the person might have endometriosis and adenomyosis also, but a small range of group that belongs to.
So, Dr. Reddy, one query we have related to this adenomyosis, why it is called as bulky uterus?
Regarding adenomyosis, see, usually there is placement, the endometrial cells from the lining of the uterus, they try to invade the muscle layer of the uterus. That is
Okay.
myometrium. So, and this again follows the same menstrual cycle pattern. So, everyone, when the person is bleeding, they also bleed and they accumulate that cells. So, the growth happens. And usually it is seen in the posterior side of the uterus. And so, on ongoing, every month it's been added and added and added. There is a thickening of that muscle layer. So,
Okay.
eventually we see a bulk uterus because of the
Okay.
adenomyosis.
So, is it really a concern factor when we are trying for conception?
Definitely, definitely, because when you have that misplaced endometrial cells, myometrium, there is a lot of fibrosis also happen. It's not that healthy endometrium. It is not the healthy myometrium also. The muscle layer
Mhm.
is fibrosed, so that the stretching factor, the contractions decrease, everything decreases in that. So definitely, it hampers the implantation of the embryo. Even if you go for an IVF or the natural conception also, there is implantation happens because it's not that healthy. It's not that healthy endometrium which we see in adenomyosis. And that adenomyosis itself will cause some impact on the by sending out negative cytokines and nuclear natural killer cells and all these things, so that it has an impact on the implantation of the embryo
Okay.
and the growth of the fetus.
Fetus. So, doctor, how we can detect this? Like, is there any particular symptoms related to our menses, periods, or anything related to this that, as a patient, I know, yes, I need to visit a doctor. There's something wrong with my system. Is it really any symptoms related to this?
Regarding both, you want me to tell endometriosis
Uh,
and adenomyosis?
First we'll talk about adenomyosis, and then we'll shift to what
See,
endometriosis.
adenomyosis, the person will not know much about it unless she has some problem. Like, say, the person, the patient, or anyone visits a doctor only if she has some complaint about it. Like
Right.
she has heavy bleeding, or there is a painful bleeding, or painful intercourse or something like that, then they visit the doctor. Then when during examination we see that there is a bulk uterus, there is invasion of the uh, with the adenomyosis, there's invasion of the vessels and all that, and the thickened and myometrium seen, and the posterior myometrium is more thicker than the anterior, and these findings we finally say that she's having adenomyosis. And the latest things are like you have the now 4D 3D scan, and there is also high density ultrasonography where you can penetrate into the layers and see. And then there's another MRI also is there. The best part, the best diagnosis is doing a laparoscopy and seeing with your eyes. What is
Right.
it? Yeah.
So, is
So
it easy to treat this bulky uterus or adenomyosis situation?
yeah. See, both are, I mean, they are painful, they are disorders of the endometrium, but they are treatable. The good thing
Oh,
about these things are they are treatable and they are not life threatening also. So once you see the thing, there are many ways of treating adenomyosis. Like you put them on minimal, when it is minimal, you put them on OC pills, regulate the hormones, or give them high progesterone, so which decreases the estrogens, so that that helps them. Or we can even introduce Marina intrauterine device with the progesterone on it, so that it slowly releases the progesterone to the uterus, thereby decreasing the adenomyosis. And there is another way of doing, if it is very bulky, then you can even go for debulking of the uterus, which improves the chances of spontaneous conception also.
okay.
Okay.
So, but doctor, you just mentioned about OC pills, contraceptive pills, and if I am in this fertility journey, so OC pills I won't be able to take. So, what you suggest for such patients who are in this fertility journey or who are trying for conception, they are thinking of natural conception, then what?
See, for the natural conception, if it is, it depends on the severity of the adenomyosis. See,
Okay.
if it is minimal, you can go for that. If there is, it is, you can even go for the oral pills like diet, diet progesterone, Dynogest tablets, high progesterones. Or and see, when you want to have a successful, you have to give some time for the
Right.
adenomyosis to decrease. See, having a pickup prior to the treating adenomyosis, you can go for a pickup. You can freeze the embryos and then concentrate on the uterus and treat the
Right.
uterus for adenomyosis. Put them on treatment for 3 months like that, or you can even give them injections, down regulated injection gonadotropins for 3 months, monthly one injection. That also helps in decreasing the, because they're all high progesterones, all
Right.
focus on the high progesterone. So you can give them, take 3 months for them to treat, and then you can always transfer, which gives us better results.
Right, right. So we can say that if you are under your treatment, like if you are doing IVF or fertility treatment, so just discuss these options with your doctor, and we are sure that doctor must have suggested you these. First, focus on the first half of your treatment, that is egg pickup, and then again the preparation part, preparation of the uterus can be done later on. So, doctor, we often talk about endometriosis. Like, I think endometriosis is a bit stubborn kind of disease. Like, it's okay, I am with you for the lifetime. Let's move ahead. So, what you suggest, like, we all know endometriosis is associated with painful periods. Other than this, any other symptom that we as a female should look for?
See, it is early on. First thing is, it is early onset. When you are
Oh,
just attained your menarche or in 18s and 20s, it is early onset. Endometriosis is always early onset, and it is happens in the reproductive.
right,
Endometriosis need not have pain. There are cases of extensive endometriosis where there is no pain at all. There's a conceive also sometimes. It is nothing
right,
like all in none law. You, if you have endometriosis, you don't conceive. It is nothing like that. People with minimal endometriosis do conceive. People may have pain, may not have pain. If
hmm,
on they are only being told when they come to a doctor because they're not having children. When they visit a doctor, we tell them you have endometriosis. So that is a factor, and they are patients who have severe pain, who can be diagnosed early, like they have pain during periods, severe pain during periods, severe pain on passing stools, like because of the increased what do you call, contractions. They have diarrhea, they have painful urination, and if they are married, they have painful intercourse. So,
hmm.
and they have nausea, vomiting, and all these things are associated with the severe forms of endometriosis. So, if it is a painful early before they get married, or early the early you treat the endometriosis, the better is the outcome. Not wait
Right.
for all the symptoms to come. So, that
Oh,
is one way of treating a endometriosis. The early the better.
early
But
the better.
as you said, it's a lifelong thing. The early you treat, the symptoms are less, everything is less, you conceive, you do everything. But it is a life, you have to go along with it, you have to bear the whole life along with it, like your partner.
Right. Right. So, doctor, what about chocolate cyst? It's at times when we talk about this, so automatically we talk about chocolate cyst
Chocolate.
also.
It's not that chocolate that we would love, all of us love to eat. It is actually the endometrial cells, they get implanted on the surface of the ovary, and then they penetrate the ovary. And then when they penetrate, again, the same process goes on. Every month they start bleeding and accumulation of that blood. On collectively accumulation, they change their color into dark red and then
Yeah.
into brown, and then they are present as a chocolate cyst. When you puncture them, you get the chocolate cyst. And if you delay it, still they become even dried chocolate cyst.
Okay. And at times, doctors just mention that when we are having this chocolate cyst, our egg quality has been compromised, the AMH comes down. And at times, doctor do suggest that we just need to drain out the material or solution from this chocolate cyst. So, is it really advisable, doctor, to go ahead with this drainage part?
See, it's like, the ovary has a chocolate cyst. If it
Mm-hmm.
is a bigger one, like 3 centimeters, it's, suppose let's take a ovary like a room. You have something unnecessary stock got into a corner of the room and occupying the whole space. Then there's little place for us to walk around because there's a
Mm-hmm.
lot of dump. It's something is being dumped into that room. In the same way, the ovary, the big cyst is there dumped into one corner.
Okay.
So the other, the ovulation to happen, the primordial cells to grow, all this is compromised. They don't have place to grow. So they
Right,
are
right.
stuck. So that's how the AMH comes down. That's how the fertility status comes down. So when only this is done when the chocolate cyst is more than three centimeters, is that
Okay.
big. The smaller ones you usually don't see 1.1 or 1 or less than that. Three
Hmm.
centimeters, yes, you need to go for a draining, but not draining. You have to enucleate it. You remove along with the cyst wall, do a laparoscopy and remove along the cyst wall. Just draining doesn't help us because again there will be a collection, right? So you have to
Right.
take out the cyst wall. Is a cystectomy done? Endometrial cystectomy, chocolate cystectomy done, so that you have again the ovary has enough space, enough place
Hmm.
for it to grow and form more eggs. So it's
Okay.
like that.
So what you suggest, like at times people says ki please, there are two views basically.
Yeah.
At times doctor suggests that please go for removal surgery of chocolate cyst, and other doctor says that please wait, don't touch your ovaries or don't do any kind of surgery with your ovaries. Just complete the first task of egg pickup and then go. At times people says that when I started my stimulation injections, so there's severe pain and the issues with my ovary starts, follicles are not growing. So how to handle all these situations?
Yeah, as I told you, unless the cyst is more than 3 centimeters, you
Mm-hmm.
don't go under a knife. Don't go for any surgeries. Don't go for any drainage. Don't go for anything. Don't let somebody touch you also. First go for the pickup.
Okay.
Okay, first go for the pickup. See the whatever eggs we get, you do that pickup. Don't go under the. If it is more than 3 centimeters, only you go for the surgery, and then immediately you can try like during laparoscopic surgeries, we can do a cystectomy. We can release the adhesions. We can do many things. What all is there? We can cauterize the small endometrium, which we feel any endometrial cysts are there. We can cauterize them. We can do many things. Then they can easily go for a natural conception or an IUI, or they don't want to waste time, they can directly go for an IVF. For minimal cases, usually they respond well after the surgery for an IUI or a natural conception. But if it is an extensive, like you know, the endometriosis is graded under 4 grades. First is
Right.
minimal, then mild, and moderate, and severe. So the mild and minimal cases, you can always try for a normal process like IUI or ovulation induction. But for the
Hmm.
moderate and severe, you better go for an IVF. But unless until if the doctor says you first focus on your pickup, then you please focus on your pickup. Don't be in a haste to get a surgery done.
Right. And how do we grade this? Like it's grading is according to the size of the cyst?
No, grading is according to the size, not cyst, the endometriosis, how where it is planted, how deep it is, and how extensive it is. It is graded according on these lines, like how where it is. It's a small cyst, a little invasion is not that much. It's only a superficial one. It's graded as minimal. A little deeper, it is involved even the tubes or the bladder or something like that. Then it is great, minimal. You can say mild one. Moderate is little extensive. You see endometriosis on the ovaries, you see on the behind the pouch of Douglas, you see on the ligaments, you see on the bladder. This is called moderate. And when everything is jam packed, frozen, the
Mm-hmm.
bladder, the uterus, the tubes, ovaries, and the rectum all are jam packed into one big mass sort of a thing. That is called grade 4, and that is also called frozen pelvis. That is a severe form of endometriosis. So, and then according to that, then the deep filtration. Sometimes these endometrios go deep, 15 like that. Then that is very painful. That there's nothing we have to do. So it's totally a frozen pelvis. You have to go for an IVF directly. If there also, if you are able to manipulate the ovaries, identify them, and see some cysts, and the pickup should be very carefully done, you have to think many things before you pick up it, because it's a frozen. You don't know where you're going. Like, you might go
Right.
through the intestine, you might go through anything. So be prepared for all those things when you do a pickup for a frozen pelvis patient. Be
Hmm.
prepared to handle any sort of thing, because if you are not very clear, you are not very confident, you might land up into some sepsis. You never know anything. You go and puncture the cyst, then that collection will be there, which might turn into any infection or anything. You have to be very careful when you're dealing with the endometriosis case of frozen pelvis, when before you doing a pickup. If it's approachable only, you do it. If it is not approachable, tell them the facts. Tell them, explain to the patient before itself that this can happen. This could be the case, this is the case, this is how I have to go, this is how I have to approach, and these are the consequences, or the complications you might have to face. So if they're comfortable, they say okay, go, you do. If not, my suggestion, according to my practice and my experience, I would tell them you better go for a donor egg only.
Right. Actually, I was
So,
coming from
yeah,
that only.
that would be
Right.
better, that would be safer for the patient.
Okay. Right, right, right. So, we have seen many cases. I can say that more than 50% cases of endometriosis, doctors suggested them with donor cycle. And uh, what could be the outcome of this donor cycle? Like, uh, what could be the success rate with donor cycle?
See, first thing is you're not stimulating the patient. So she's away
Um,
from the hormones and all that stuff which we give for 10 to 12 days. So she's not being stimulated. That is one good thing. She's not under any hormonal therapy or anything being pushed into her body. So that way she's clearer, she's happier. We take out the donor, we fertilize it with the husband's sperm, then form embryos, which would definitely be of good quality and good grading, because as we are going for a donor. And that, then you have to prepare her simultaneously the uterus. If there is
right.
adenomyosis, you treat that first before you transfer. If there is anything, you do a hysteroscopy and find out if there is any adhesions or any synechiae or anything in the cavity of the uterus. Confirm that her endometrium is good enough for us to transfer. Confirm the blood flows. Confirm the contractions. Confirm everything, like biophysical profile of the uterus, where you study each and every layer of the uterus, like what is the contraction, what is the blood flow in the myometrium, what is the blood flow in the endometrium, what are the contractions, how long they are taking, how many contractions you can see in a minute, and the line, triple line, or and the flows, the pulsatile flow, the resistance flow, all these you should be very perfect, because already the patient has suffered a lot with endometriosis. By giving them a child, you'll be at least trying to forget her pain, at least for those 9 months or something. You be giving her a pregnancy. So we have to be very apathetic, and we have to treat her properly. And we are confident that lining is in a receptive mode. You can transfer it. The success would be better. At least I can say 40 to 45% you can expect a success for those patients.
Right. And I would really like to add a point over here to our viewers, that when doctors suggest us donor cycle, so it's just that doctor is not finding the other way out for you, uh, because doctors really want you to have good pregnancy, good conception time, and delivery of healthy child is really important. So whenever doctor is suggesting you donor, so don't judge the doctor. Just see on the brighter side of it, that yes, you really need it, and doctor is suggesting just for your future healthy outcome. So doctor, we have one query over here related to adenomyosis. So is debulking surgery possible in case of diffused adenomyosis?
In diffused adenomyosis, debulking, it will not be of any help, because debulking is only done when the posterior layer of the uterus is very big, like bulky. So you are not supposed to approach the endometrium, the inner layer. Only what you do is you go to the posterior surface of the uterus and just give
Hmm.
a spindle incision, remove only a bulk of it, only the myometrium or the where you find an adenoma. See, adenoma, there's a lot of difference between adenoma and the fibroid. Mostly people get confused between a fibroid and an adenoma. Fibroid, you have a proper lining, a proper border, and all that. You can easily remove it. But adenomyosis is all like you never know where is the end, where is it. It's only a bulk. It is there.
Hmm.
So if that place, if you can do debulking, where is it? We don't know. If it is in the posterior surface, we can happily do a spindle. We can remove a spindle shape piece off from the posterior surface of the uterus and do a suturing, which would help them. But
Hmm.
exactly, we should know what is it, whether it can be done, if it is helpful for them or not. Before you do, go for debulking. You have to decide properly, do a scan, do an MRI, whatever it is required, and then
Hmm.
know if it is helpful to you, only you undergo it. If it is
Oh,
just like that, don't go for it.
so doctor, is there any negative effects of this debulking surgery?
Definitely, because we are removing a piece of this uterus, the posterior myometrium surface we are removing. So when we
Hmm.
suture it up, you have to wait at least for 3 to 4 months for it to heal properly. Uterus is one organ, it's easily healable. Okay,
Right.
and then, but when you become pregnant, it's a good thing. You become pregnant, you have to be alert, because once the baby is growing, there's a weak point at your endometrium.
Oh,
I
right.
mean, uterus. The uterus has a weak point, which is
Hmm.
this debulking part. So you
Right.
have to be very careful when the mid trimester of your pregnancy. Be careful.
Hmm.
Visit the doctor frequently. Have a proper checkups, and take proper bed rest, whatever is required for you till your delivery. That's the
Okay.
only
Right.
chance that there could be, if the point is very weak, it can land up in a rupture. So that's the
Okay.
risk. You go for the debulking surgery. There is a risk of rupture uterus in the third trimester or second trimester, 6 months, 7th month, 8th month, anytime. So you have to be under the observation of a doctor all the time if you conceive
Right.
from the second trimester.
Right. And I think that's why it's really important to choose the right doctor. And viewers, if you are in Hyderabad or any other city and you want to meet ART fertility clinics, specialized experts, doctors, please do let us know. Each and every point of your fertility journey is really important. So please do select your doctor rightly at the right time, because age के साथ साथ we are also aging, our ovaries are also aging, so age is really important factor. So doctor, what are the complications if we are having both of them? Usually one or two people ask that I have adenomyosis along with endometriosis, so what could be the complications and how to treat both of these in one go?
You have to treat the endometriosis first. If it is
Hmm.
big enough, as I said, surgery, or do a pickup first. Then go for treating adenomyosis. How vast it is, whether it's only if you like put them on some progesterone treatment for 3 months before you go for a transfer. And
Hmm.
wait for everything. Don't be in a haste. You have to have time, you have to take your time, you have to give time to the doctor also to do a pickup, to treat both the things simultaneously. If both are treated in a proper way, if the proper person does that in a proper way, definitely you will end up in having a pregnancy very shortly. And again, the adenomyosis, if here again, as you said previously, age is very important, very important. Age is very important in every, it's like a clicking of a clock. Every tick tick tick, you have to be very careful. You can't stand on that. You have to run along with that. You don't waste your time. Before you have any symptoms, you go to a doctor who can really treat you properly, because they are, see, infertility, IVF babies and this and that, it's become very common these days. You can treat, anybody can treat a IVF, anybody can do an IVF, but the person who's doing IVF should know each and everything they are treating. What would be the consequences if I'm taking this subject, if I'm doing this, what are the consequences? We should know that before we start a treatment. We should know the complications of it. If I'm giving ovulation stimulation, What is the consequences? Suppose I get more eggs, what are I'm going to do? Like if I get no eggs, what am I going to do? So unless you study this, simply it's not like you come, I do it, I finish up, I transfer, you go, I go, I you go. That's it's not that easy. The IVF is not that easy. It looks easy for everybody, for the new people, but it is not that easy. You have to, every step you have to think twice, because you want your patient to be happy, because they are not
Right.
deceased. I keep telling them they are not deceased. They are not. They are only deceased in their mind. They are depressed socially, economically. The whole world is against them. You are the only hope. You are the only doctor. Is the only hope for them. The neighbors, the relatives, the mother-in-laws, my father-in-laws, all of them have outcasted that girl because she doesn't have a baby. So you have to keep that in your mind and treat a person. You have to give her a smile on her face. That should be your outcome, not just treating and saying, "Oh, so sorry, your endometrium is not receptive. What should I do? I did my best." That's just not that. We should be able to answer to each and every query of us. We should put her on the same page as I'm treating. Every day she should know what's happening with her body. What is how my drug is giving her the, what is the response she's getting from my drugs? What is the scan being told? Everything she should know, because it is her body we are going treating, not ourselves. So we should know what we are treating and whom we are treating, and everything she should be on the same page as I am today. Like if I'm doing a scan, she should know what is the result of the scan, what are the blood reports, what are the things. If you are very clear and transparent and ethical in your approach, I think anybody can do wonders in this IVF thing. You have to be that. You have to be very empathetic first thing, because you are the only hope. You're the only person who can give her the child, whatever it is. If you're going for a donor, you're going for anything, that's a different thing, but you are bringing a smile on her face. And one more thing, what I would say is, for adenomyosis, if it is very extensive and very bad shape, I would prefer you going for a surrogacy also. Surrogate, that is
Okay.
the ultimate. For a bad adenomyosis,
Mm-hmm.
there's no other way. You just can't treat her. So you would suggest her a surrogate. That is the ultimate.
So, adenomyosis is such a bad thing.
Yeah.
Okay. I only thought that it was just related to some hormonal disbalance in our body.
This balance, it happens in the initial stages, but when it grows and
Mhm.
grows and grows, it becomes that bad.
Oh, oh.
Over the
So,
years, if you're not treated properly early, that's what I
mm,
said. Initially, the early the treatment, the better is the outcome. You don't fool
right,
your dog. You don't show yourself, get scared. There's that. The later, the outcome is bad. So I request all the people who have little, let the doctor decide for you what has to be done. If
right.
they say
Don't delay
normally,
it.
don't leave it. Don't hesitate to visit a fertility specialist, because she is the right person to tell
Right,
you. If she's not there only to do IVF, right? She's there to help you in everything. If you're normal, everything is normal with you, she would write some medicines and give you, and you can easily conceive normally with the oral drugs and the timing of the intercourse. Those are the simple things which she does.
sim-
And then if she is unexplained or something desperate, then only she'll advise you for an IUI, the minimum basic things in such things, in endometriosis, adenomyosis, something very grave, and there's nothing she can do. Only then she will advise you IVF. So most of the patients I have heard, they said if I go to an IVF specialist, she does nothing but IVF. It's not like that. It is not like that. Please try to understand us. We are not like those doctors. At least ARTP doctors are not that way. We are very sympathetic, we are very transparent, and we are ethical. We help you, we are there to help you people, not to discourage you or to, you know what, no, there's no commercialization also here.
right, right, right. So that's why we only suggest that please do visit, don't delay your visit to the doctor. And fertility, entering the gate of fertility clinic doesn't mean that you end up doing
Yeah.
IVF. The possibilities, and even we have seen many cases where simple letrozole cycle or simple IUI like works best for the patient and she conceived. So
No,
again,
OSA also work very well. No, I'm
Right.
telling you, because in my experience, I have seen one patient. She had come in 38 years old. She's saying,
Oh,
I said, What is it? Why did you come today? There is hardly any eggs here. You're in a very desperate, bad position. Your AMH is so low, there's hardly one or two eggs. But you are there to do IVF. I said, Yes, I can do IVF. From where do I get the eggs? She said, It's not
right.
like that. IVF, you can do anything, no? She said, No, 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 you have to go for donor only. I never knew. I was running around the place with my job and all this thing, thinking IVF specialist will look after it. It's nothing. We can't produce eggs. So I want that. All that was a really experience I had. I was shocked to hear that you are there not to do everything for us. And we can't. We do whatever is available with you, not something from outside. Then I
Right.
told her, "This is you have to go for a donor." Then finally she agreed. We gave her a baby, a beautiful baby. So people who are listening think that IVF specialists have you need to have something in your body. You need to have a uterus. You need to have ovaries with proper AFC. We can help you out.
Right, right. So, please, viewers, don't delay your visit to the doctor. And if you are in Hyderabad, you can always visit Dr. Reddy. And if you are in any city of India, please do visit ART fertility clinics for your further treatment. For just visit once and see how doctor can help you without delaying your visit. Just send us a simple message, mail or SMS or WhatsApp message on our official number, and we will directly connect you with the topmost experts of India. Dr. Reddy, thank you so much for joining today. And
One second. Can I take 1 second?
Anji,
Yeah.
please.
I want to give a thing to all the viewers who are watching this. There's a new film produced by Hillary Clinton in raising the awareness of the endometriosis.
Oh, great.
A new documentary been released. It is produced by Hillary Clinton. It is called Below the Belt, a new documentary directed by Shannon Korn and executive produced by Hillary Clinton, which shows the stories of this endometriosis persons. If you have time and if you can get that, please watch that. The title of the movie documentary is Below the Belt.
Below
You
the
can
belt.
watch.
Right. I think we all must watch it just to gain knowledge, because it's not that if I am having endometriosis, then it is useful for me. No. Possibility is that after watching it, it may be possible that I may be able to help another lady, another female who is dealing with. And it's not always that we look upon the fertility lady, or the lady in her fertile period, reproductive age. You just guide or talk to the younger generation also. Teenagers are also dealing with this immense situation where they have very painful periods. So please do help spreading the awareness, so that when they reach the age of reproduction, they don't get hassled up or their situation worsen. So please take care of your health along with the health of other females. Thank you, doctor. Thank you so much for joining today. Thank you.
Thank you. Thank you so much.